Good morning and welcome. This is the fourth webinar of a series on the value of applying analytics to real-world problems. These webinars are an initiative of the Informs Practice section. In this webinar, we will hear about how operations research and analytics can be used in supporting public health interventions for infectious diseases. I am Patricia Neri. Dr. Carrie Beam and I are the organizers of this webinar series. Dr. Pinar Keskinokak and Dr. Julie Swan are the speakers in this informative webinar. Dr. Pinar Keskinokak is the director of the Center for Health and Humanitarian Systems at Georgia Tech and current Informs director. Dr. Julie Swan is department head and A. Doug Allison Distinguished Professor at NC State University. This webinar will be available on demand, and we will make the link available at the end of this presentation. Also, at the end of this webinar, there will be a networking event organized by the practice section. You can stay on this Zoom session to participate. Carrie and I want to give special thanks to Dr. Pelin Peckham, who helped us organize this webinar. Dr. Keskinokak and Dr. Swan, welcome.
Thank you so much.
Carrie, Patricia, Pelin, and all of the practice section leaders and members, and all of you attendees who are with us today. So I'm going to go ahead and share my screen to get us started. Can everybody see my screen? Julie, great, okay. Julie and I have collaborated in this space of infectious disease modeling for many years. And the way we structured this webinar, I will give a high-level overview of infectious diseases and specifically how we model them. And then I will turn it over to Julie, and she is going to give some specific examples, especially related to COVID. I know many of you have it on your minds, so we thought we'll share some examples and results specific to COVID. And many of our work over the years has been in collaboration with our colleagues and students. So upfront, I would like to acknowledge them before we start the webinar. All right, so there are two key components in infectious disease modeling. One of them is the disease progression in an individual, which we also call the natural history. And then the second important component is the disease spread. So how it progresses in an individual and how it spreads from person to person. So here's an example from COVID about the progression within an individual or the natural history. So initially, because COVID is a new disease, pretty much everybody was susceptible. None of us had immunity, non-immunity to this disease. So we were all in the susceptible bucket. And then when a person gets exposed to someone who is sick with the disease, they go through different paths depending on their age, health condition, and just some random factors. So typically there is a pre-symptomatic stage where the disease is brewing, but they are not showing any symptoms. Some people go through the disease entirely asymptomatic or very, very mild symptoms, and they recover typically if they go through the disease that way. Others may start showing symptoms after some time. In some cases, these symptoms might get quite severe, may require serious treatment or hospitalization. And unfortunately, in some cases, these complications could lead to death. So other cases, for the most part, they recover. So again, depending on the person, how a person progresses across these possible paths, which of these paths a person will go through, how long they stay at each of these stages, the severity of their symptoms. All of these are dependent, again, on the individual and as well as some random factors. So some of you may have heard, if you read the literature in this space, SIR models. So S for susceptible, I for infected, R for recovered. So these are typically the basic, simplest form of these models. And one step further is the SEIR models. So that we are kind of capturing a bit more of the detail that's happening in the disease progression. And in my picture here, if it looks too complicated to you, just that red bubble there is basically the time where you are infected. You may be infecting others, and then the green part is kind of the end. We can all put it into the recovered bubble. So that's the picture I'm showing is a little bit more expanded version of these simpler models you may have seen in the literature. Okay, so now that we captured the disease progression in an individual, let's look at what happens in terms of transmission. How does it spread from person to person? So there are actually many different ways of spread. So the human to human is probably the first one that comes to your mind because that's the one that we are most familiar with. Most of the respiratory diseases fall into this category, including COVID, and also some of the sexually transmitted diseases. So let's see an example from COVID. So here, the spread really depends on how people interact with each other, the proximity of these interactions, as well as the duration or intensity of these interactions. So typically, our interactions are most intense and longer duration if we live in the same household. Then next comes our peer groups. Depending on age, it could be schools or workplaces. Not as tight as the household interactions, but still, if you go to the office regularly or children going to school, they would be spending time quite a bit with their peers. So then comes the community interactions, which are not as intense as the household or peer group, but still play a role in the spread of the disease. These are things like going to a grocery store, or, in the days when we used to go to concerts or theater or other kinds of events. So when we create a model, Julie's gonna go through this a little bit more. In our work in COVID disease modeling, we use what we call an agent-based model. And we actually model each individual in a complex simulation, and then we also model their placement within this whole group, households, community groups, peer groups, and so on. So basically, just like in real life, in our simulation, agent-based simulation model, an individual has a household group, a peer group, a community group, and we also capture the different interactions between them. So as we do this, I'll talk a little bit more about the data, but we have to utilize a very vast set of data, such as household statistics, age, classroom sizes, as well as trying to capture some of the mobility and interaction between these groups. So this is just a big picture example from COVID. All right, so this is the human-to-human contact. Some infectious diseases are passed via vectors. Malaria is a good example. It's transmitted not directly from human to human, but via mosquitoes. So in this case, actually, things get a lot more complex. If you thought COVID was complex, think about some of these other diseases where we not only have to model the human population, but we also have to model the vector, the mosquito population, and the progression within each population, as well as the interactions between these populations. And of course, add to it the complication of environmental factors, such as, the water bodies, temperature, humidity, and so on, and other risk factors such as age. So it can actually get very, very complicated for some of these diseases where we have to model separate vector and human populations. So environment plays a role in the spread of some of the diseases. Even for COVID, this is true. I'm sure you heard the ventilation and so on. Those play a role in how quickly the disease might spread. But for other diseases, this may be even more crucial. Some examples are cholera, typhoid fever, or even salmonella, where, for example, the water, whether or not we have access to clear water, could play a role. And then here's an example from cholera. Obviously, regionally, say if you look at the entire world, what are the regions where we have higher risk? You will see differences across the countries around the world, but even within a country or even within a smaller region, we might see differences in terms of risk. So for cholera specifically, the water, whether or not people have access to clean water would have a big role. So on these two maps, you can see the kind of geographical situation and something about the infrastructure. And then you can see the risk factors. And even within this one area, we can see how the risk of the disease might vary depending on the environmental factors that we have. So quickly going back, so some of these diseases can be really, really complex to model and to understand. I think guinea worm, Julie and I have done quite a bit of work on this in collaboration with the Carter Center, is a good example where it's a parasitic disease, and it's actually humans and copepods in water play a role as a host. And the cycle can be very long in this case, averaging in a year between, a human actually getting the disease, let's call it that way, and then showing symptoms, which is the worm being exuded. So it's a very long cycle, which actually makes it quite difficult to analyze and understand some of the dynamics because of this long cycle compared to COVID, for example, which is relatively short from being exposed to getting to the point of being recovered. So anyway, I hope this gives you an idea, a big picture about the variety of infectious diseases and how each one has different elements and what we need to keep in mind when we try to model these diseases mathematically. Okay, so going back to environment, so some of these environmental factors are not that easy to change over time. So for example, if an area doesn't have access to clean water, this is not something that we can fix over time. So interventions can vary depending on their impact, what they focus on, how quickly they can be implemented, and then of course the behaviors, to what degree people actually comply with the recommendations and the interventions. So all of these play a role in how the disease is spread among people geographically and over time. So in our mathematical models of these diseases, we first try to understand, if you do nothing, how would this disease progress in an individual and also across the population geographically and over time. So we try to project the spread of the disease, and then we monitor the specific metrics and outcomes of interest, which I'm going to discuss in a moment. And then we try to quantify, evaluate the impact of different interventions and outcomes. And keeping in mind, again, that whatever interventions we put in place, people may or may not comply with them 100%. There is usually a variation in the compliance level. As we know with COVID, we hear recommendations about masks and physical distancing, but we don't necessarily see 100% compliance with these. It varies over time and by person. And then comes the important question of resource allocation. We have limited resources for implementing these interventions. What's the best way to allocate them so that we get the biggest impact on the outcomes or metrics of interest to us? And this is, I think, an area where we see a lot of potential in using analytics, particularly operations research methods such as simulation and optimization, as well as some of the other predictive models, combining them with models knowledge from epidemiology with the methods coming from OR, how to best allocate our limited resources. That's, I think, where there's a lot of potential for our community to for further impact. So let me talk a little bit about the interventions. So they could be pharmaceutical, such as vaccines, antivirals, and I'm primarily giving examples related to COVID. For other diseases, of course, it differs. Or they could be non-pharmaceuticals that are primarily focusing on behaviors, such as school closures, travel restrictions, and so on. And some of these are combined strategies. For example, testing, tracing, isolation. We know from practice, and we can also show mathematically that these interventions are only effective, or you get synergies in their effectiveness if you implement them in combination. So for example, if we just test but do nothing else, yes, we will get knowledge about the spread of the disease, but that's not going to help us slow down or stop the spread of the disease. So we need to combine it with tracing, isolation for it to be effective. So as I mentioned before, behaviors or compliance with the interventions might change geographically. It may change over time, and we may also see different levels of compliance across subpopulations. So all of these need to be taken into account when we do our projections in the disease models. We need to capture some of these behaviors or compliance so that the predictions will be more in line with what we might actually see in practice. And again, it becomes very important to find an efficient and effective way to allocate our resources, how, when, where to use them, considering these complex dynamics in the disease, as well as the limited resources, whereas the resource availability might also change over time, as well as geographically. So it's a fascinating combination of complex optimization problem. So metrics of interest, and Julie is going to dive into these a little bit more. So typically we try to monitor these metrics by age group, geographically, by subpopulation, so that we can identify if there are any disparities, inequalities, for example, in how people are affected. So we would like to know about the new infections per time period daily for COVID. Many of you may have been monitoring these numbers. For the US, for the world, or for the state or county where you live in, if you are in the United States, or depending on wherever you are. We are typically also interested in the timing and the magnitude of the peak. This is the time where our new daily infections reach the maximum. So this is important because that's when we expect our resources to be most stretched, whether it's hospital beds or ventilators or other kinds of resources. And some of the interventions focus simultaneously on reducing the number of infections, but also pushing down the peak. Again, you may have heard the term flattening the curve, right? So that's basically, we want to push this peak down so that we have less strain on our resources. And we ideally also would like to push the peak further in time, which gives us more time to prepare and to better respond if and when we reach that critical time. So we are, of course, interested in the total number of infections or the total percentage of population infected by the end of the pandemic, if you think about COVID. And we monitor the number of people hospitalized or number of people or percentage of people who die. Again, remember by age, geography, and so on. And all of these numbers or the metrics that also help us come up with estimates about our resource needs, which is very important. So how many hospital beds, ICU beds, ventilators, and so on we might need geographically over time as the disease progresses and continues to spread in the population. So the models help us not only project these outcomes, these metrics, under different intervention strategies, behavioral scenarios, but they also help us estimate some of the resource needs so that we can better prepare. So just a small example from resource allocation. This is the work Julie and I had done with some collaborators on cholera vaccine allocation. And it's a relatively simple one where we looked at strategies. Okay, what if we prioritize this limited amount of vaccine by age group? So in this case, children are at higher risk. So maybe prioritize children, and then if there is enough vaccine available, then go into other age groups. And then what if we prioritize by region only, focus on the high-risk regions, and then see what happens. And then we also tried a combined strategy by using an optimization model. What if we find the best way to allocate this vaccine, not only by age, not only by region, but by looking at this in combination and actually write a model to optimize the allocation over time. And what we found that allocating the vaccine by simultaneously considering age and region actually gives us a significantly better result in terms of the number of cases and deaths we might be able to avoid. So this is just, again, one example of how models from or methods from operations research and analytics can be used in better allocating our tight resources, saving lives or improving lives. So creating these models and validating them can be quite complex. So this is just an example from the COVID-19 agent-based simulation model that we have. So we have parameters that specifically relate to the natural history, as I mentioned before, the disease progression in an individual. And then we also have a lot of parameters that we need for resource estimation. I won't go through this in detail, but just to give you a glimpse of the complexity of these models in terms of how we find, fine-tune, fit, and over time, as we learn more about the disease, update some of these parameters to get a better fit with our models. This is again a big space, transmission patterns, probabilities, indoor, outdoor. This is more about the spread of the disease, which gets very complex because we can't do controlled lab type of environments easily, especially if we are thinking about larger groups or outdoors. We have to take into account the variability about the impact of certain interventions. So, for example, we know that using face coverings helps reduce the transmission, but to what degree depending on the type and how people use it. Surveillance is very important. Initially, a lot of the surveillance done for COVID was symptom-based, but then as our capacity increased, now our testing actually includes people who are asymptomatic, and we find the disease more and more among asymptomatic people as well as our capacity increases. So these are just examples of how our understanding of the disease, especially for a new disease like COVID, might evolve over time, and if it does, we are able to fine-tune some of the model parameters and improve the model accuracy as well as the decision-making over time. So again, Julie is going to talk more about this, but I cannot emphasize enough the importance of behaviors, what we do individually, what we do in our households, in our communities. That really has a huge impact on what happens in terms of disease spread. So I think this is pretty much all I want to cover in terms of big picture. So now I'm gonna turn it over to Julie, who is going to give more specific examples about COVID and how we use these models in decision making.
Thank you very much, Pinar. I will ask if Pinar or others on the phone can hear me. Pinar, can you hear me? Yeah, great. Thank you so much. Thank you for joining us today, and I do encourage you to submit questions as we go along so that you won't forget them. We're going to be covering a lot of material today. I'm going to talk to you about some results that we have from modeling COVID-19 using these using mathematical representations of some of the pictures that Pinar showed you, and then using computer simulations. And there are many others who contributed to this as well at Georgia Tech with Pinar, and more recently at North Carolina. Soon, we'll also be working with the Centers for Disease Control and the Council of State and Territorial Epidemiologists, and we will be doing modeling to help support decision making. So today I'm going to talk to you about results that we have from North Carolina or Georgia, but we're also structuring the model and what we're doing so that we can expand it to other states based on what's of most interest to those groups above. So as Pinar mentioned, our agent-based network is built into these communities with households and workplaces and schools and all of these different things. There is a lot of different data that we put into the models for North Carolina and for Georgia, and that we can then expand to other states. You'll see here transportation and movement between locations. We've got all kinds of different information at the tract level. Recently, we've added in race ethnicity along with the diabetes rate, which makes you at greater risk for severe outcomes from COVID-19. And then, even looking at more things related to policy, like potential school plans and mask covering rules and shelter in place and those kinds of things. So when we're building the model, one of the things that we have to do is validate, as Pinar talked about, and certainly behaviors are one of the important things that goes into that. And on the left, I'm showing the daily estimate from the model of true cases. Now, true cases is not what we see in the news. What we see in the news is lab confirmed cases. And we expect that there are a number of cases that are not fully identified, either because they are asymptomatic or because there weren't tests available at a particular point in time. So we also have lab confirmed cases that are reported in the news. And in the model, when we go from true cases to lab cases, one of the things that we do is we look at what the relationship between those is. On an average basis from approximately March until July, we concluded that it was approximately, there were, for every one case identified by a lab, there were about 6 cases that were out in the community in reality. And there are a number of ways that we can do this. We can look at the death rate as well, but this helps us understand where we are. And you can see on the right-hand side, we've got cumulative lab cases, and the green is the actual, and the red and the blue are 2 different behavioral scenarios. One with low compliance, that's the blue line here, low compliance with voluntary household quarantining, and the red line is high compliance with household voluntary quarantining. We also look at hospitalizations and deaths, and we can validate on those as well. On the left is a daily estimate of hospitalizations under 2 behavioral models. On the right is the total deaths. The blue and the red come from the model, and then the green line comes from the actual data. Now, in reality, there could be some undercounting of deaths nationwide. There certainly have been some, particularly in the states that were hit earlier and harder than other states were at that time, like in New York and Michigan and others. There's probably not as much undercounting of deaths in a state like North Carolina or Georgia. And what we see here in this particular picture that I'm showing you, and this model results is from a few weeks ago, this is not current, but the deaths that are reported are just a little bit lower than what we're seeing in the model. And there are a couple of reasons for that, and it could be related to whether we have things going on with young people, and that did happen in the summer throughout the country, where there were more young people getting the disease than had previously been happening. And so that did tend to reduce that death rate a little bit, since death is partially related to mortality. So I'm going to show you now some of the recent results. These are just from a couple of weeks ago. This has been submitted in paper form, but we're not waiting until papers completely come out before we start to talk about the kinds of results and findings. because it's really important that if we truly believe something and we think the science supports it, then we want to add that voice to the public and to help have impact from all of this different analytics work that we're doing. So as Pinar mentioned, there's been greater evidence about masks in recent months. And, you know, one Lancet report was a meta-analysis of a whole bunch of different mask studies. More recently, Duke University published a paper looking at different kinds of masks, all the way from the best case scenario with the N95s that are appropriate for medical situations, down to, you know, homemade cloth masks, even bandanas and neck gaiters. And what they found is that the high quality mask like an N95 is great, and those homemade ones that have multiple layers of fabric are really pretty good, and that the neck gaiters and bandanas are not very good. So in this next simulation, we're going to look at the impact of masks on the population if a large number of people start wearing the mask. In North Carolina, the governor did put in an order on June 24th that masks are required indoors or any place in which you cannot fully physically distance. So in this, we're going to assume that masks are 50% effective initially. This is probably a low end of what I think is really true of the masks that I see out in public. And the picture that I'm showing you here is the infectious people over time from the, we started this simulation back in March and then moving forward. The yellowish one that's at the top here has no masks at all. And this does have some kinds of things in place, like voluntary quarantining of the entire household when there's someone sick. And it had the shelter in place that was put in place in North Carolina back in March, April, and a slow phased opening of the state. Now, one of the things that you see in this picture is that if 60% of the population wears a mask, that's this arrow that I'm pointing to, this bluish line here, and that would greatly reduce the cumulative infections, the total infections that we expect to see. It would reduce it from approximately 36% from this scenario down to 27% for this scenario. So masks help. Certainly, the more people who wear masks, the better. You can see that going from the top down to the bottom. But one of the things that struck me when I first started seeing these results is that this level of mask compliance and mask quality did not completely stop the pandemic in its tracks. So we went a little bit further, and next I'm going to show you some of the results where we looked at the role of mask quality in what's going to happen with the pandemic. So this one, we have a couple of different scenarios. Here we're looking at 60% of the population is wearing the mask, and we have different mask effectiveness levels from the really low case, 20% effective, up to the highest case, 90% effective. And as you go from 60% effective, which is pretty close to what we had on some of the scenarios on the previous page, down to 80% effective, this green line, you get a big impact. In fact, if you had everybody in the population wearing masks, but the masks were of lowish quality, average 50%, then you're worse off than if you have just 60% of the population wearing a mask that's 80% effective. We've certainly seen a lot of messaging around wearing of masks. I do think that this also needs to be stepped up a little bit and to talk about that different masks have different performance. And what we know is that multi-layer masks tend to work better than a single knit piece of fabric, than a bandana, or than a simple neck gaiter, which can sometimes be worse than no mask at all because it takes large droplets and makes them small. So these are some very recent results. Then continuing with the masks, one of the things that we're looking at is the geographical differences. And here we're just considering that mask compliance is uniform throughout the state. Anecdotally, we think we see that that's not true, but we don't have a good data source that really tells us what it is if it's not like that. Anecdotally, we think that the compliance with masks is higher in urban areas or in areas that seem to have been a real hotspot for COVID-19, and is lower in rural areas. But in this, we assume that it's uniform throughout the state. And here we're looking at cumulative infections, and there is a little bit of uncertainty around it. Here, the uncertainty is based on where the disease is starting and exactly what direction it's going after that. At the top, we have 0% mask wearing, then we have 60% compliance with masks, and at the bottom, 100% compliance with masks, but here masks are only 50% effective. And you can certainly see that as you go to more people wearing masks, you get better. One interesting thing, though, is that the gap between this darker blue line for 100%, this is the urban one, and the next line in the set, the gray one, that is the rural one, that gap is getting bigger as you go down this chart. What that seems to suggest is that the mask wearing is actually even more effective in the rural and suburban areas than it is in the urban areas. Not that it's not needed in the urban areas, clearly it is, but in some sense there's a different level of infectivity of the disease because the disease comes in different contact in an urban area than a rural area. And in general, we do see cumulative effects that are worse for urban areas, cumulative infections that are worse for urban areas than rural. This is a summary of those results and look compared to the baseline of no masks, how much benefit you're getting. So you're getting somewhere between, this is about 25% benefit on the left, going to 40 or 50% benefit, going up to closer to 50% benefit. And this one's not shown on the left-hand side, but this is the one where the mask quality goes up a little bit to 80%. So that's really important to try to keep encouraging people to wear face coverings and higher quality face coverings when possible. So I want to talk a little bit, this is really new work. I don't think anybody outside of our group has seen it yet. We certainly know that there are disparities in what's happening with COVID-19. If you look at the rate of cases, the rate of hospitalizations, the rate of deaths, you will see that all of those are much higher for communities of color, including Blacks, Hispanics, and Native Americans. And today I'll talk mostly about Blacks and Hispanics since the data is really incomplete on Native Americans. And in this particular estimate from the CDC, the rate of cases is between 2 and 3 times higher for these populations. The hospitalization rate is almost 5 times higher, and the death rate is higher as well. Now, interestingly, the Hispanic death rate drops, and this is largely because of the age difference between Hispanics in the population and whites in the population. There are more children in Hispanic communities than there are in some others. The median age in the Hispanic community is lower than it is in whites. Now, there can be many different reasons that there are more people of color who are being infected, more of them who are being hospitalized, and more of them dying. And here are some examples of those. But we can use analytics to start looking at that. So here today, I'm just going to talk about 2 of them, where we have implemented the race ethnicity at the census tract level. And we also have housing size, the size of the household at the census tract level. I wish we had even better data where we had cross distributions, but that's not available from the census. And we've also implemented rates for diabetes, which is just one factor, but it is a lower bound on some of the differences in comorbidities between these populations. So today I'm showing you the results from North Carolina with these, the race ethnicity added in. This on the left-hand side is cumulative cases, and in our simulation, we do find that Hispanics have a higher case rate than whites. Now, this is really only due to 2 things. It could be where they live in urban areas versus rural areas and how fast the disease gets there and how connected that area is. That does not seem to be driving it. It could be because they have more people in their family or more children in their household. And this does seem to be one of the drivers, even though schools are not in session in this particular model. So and this is consistent with what we see from the true data for North Carolina. Then on the right-hand side, I'm showing you the mortality rate from the model. And the mortality rate, you can see here that Blacks have a higher mortality rate than the other 2 groups. And this is probably driven not by age, because the median age of Blacks is not higher, but likely by the rate of diabetes in the population. Now, this is only 2 of the factors that I showed you on the previous screen. There are likely many more, including what kind of job someone has, whether they can telecommute or not, and a number of other things that I listed on the other slide. So we are continuing to look at this, and this is certainly something being discussed by the CDC and others, and it is also being discussed in the talk about vaccine and how to distribute. Another interesting study, this was led by Pinar and her group, looked at school openings and what it might do to the disease spread if K-12 schools were opened. Now, on the call today, there are people who are from all over the country and perhaps all over the world, and things may be different in different cities or states where you live right now. Here in North Carolina, in my county, we have not had K-12 schools in session in person. It's all been remote, but they are going to be opening up very soon in the next few weeks. And one of the things that Pinar's work with the team showed is that if you just went to a hybrid model where, let's say, half of your students are in person in the classroom and half are remote, then that greatly reduces your risk. It takes you down from these dotted line cases down to the solid line. And that's really important. And that is happening in a number of different school systems as they've asked some of the people if they would like to move to virtual, and some have chosen to do that. And then we also have these alternating schedules that are being put in. And so Pinar's model was shared with the Board of Education, and I shared the same results with the North Carolina decision makers. And shortly after that, it was announced that that would be one. I'm not saying that we were the only factor, but we did see that this was an option in North Carolina, and that is what they've moved to in Wake County more recently. There's some other things that we're doing more recently. Again, I'm showing you things that really nobody else has seen yet. We're really looking carefully at the lab confirmed cases compared to the true cases. And this is really important as we expand beyond the first states and go to others. And we need to be able to validate the results and adjust any parameters as needed. And one of the ways that we can do this is that we can take the true death rate from COVID. That's not the death rate that you see in the news, because that's really the case fatality rate of the people who have tested positive or go to the hospital, how many people die. That data is really biased by the fact that there are many cases that are not being caught through testing. But if you look at other countries like Germany and South Korea, especially in the early days, and China as well, they were testing everybody. So they were really missing very few of the asymptomatic or mild cases. So you can use that to get this true infection fatality rate. And it's probably about 0.5%, or at least it has been. It's possible that it is dropping with additional treatments that are becoming available and more knowledge building up about the disease. You can also take how long it takes someone from an exposure to die. And using that, we can estimate what the lab multiplier should be to get the number of true cases. So here I'm showing you results for Georgia, the blue line, North Carolina, the red line. Now, testing changes over time as well as other things. And so here it's bigger near the beginning of the data I'm showing you, and then it's getting smaller, but it does seem to be converging. For North Carolina, it's converging to about 4, and Georgia, it's closer to 5. We estimate from this and other things that we've done that right now in these two states, approximately 1 in 4 to 5 cases are being caught through testing. So that still means that there are a lot of cases that are not being caught through testing, and that's important to think about. That's one reason that when I look at what's going on in a particular state or other location, I often first look at the mortality, because more of those cases are caught than ones that are not necessarily in the hospital or leading to death. One of the other things that's important as we're trying to continue to build the results for Georgia and North Carolina, but also as we expand to other states, is to understand how behaviors are changing. So here we're using some new data sources that have become available. I'm going to show you some data that I think comes from the Google mobility data. There's also data from SafeGraph and Streetlight and Bureau of the U.S. Department of Transportation, or the Bureau of Labor and Statistics now. So we are starting to see more kinds of data. And this is often drawn from cell phone data. So what I'm showing you here is the locations. These are the counties in North Carolina attributed to rural, suburban, or urban. And on the left, I'm showing you the people that Google estimated were going in physically into their workplace. And on the bottom right, I'm showing you the people who are estimated to be partaking in retail and recreation activities, including movies, museums, bars and restaurants, and others. And of course, you can see here that there was a dip in activity compared to the baseline back from January. And this corresponds to the shelter-in-place timing in North Carolina. And then it went up, but it's not completely back to normal in North Carolina. Another thing that I notice in this particular picture is that rural is on the top, that's the blue line, and urban is on the bottom, that's the gray line. And what this says is that in urban areas, there are more people who are either out of work and staying home, or more likely there are people who are working from home because they're able to work from home, as many university and business people can who are in our space of analytics. On the right-hand side, we see a similar type of result for retail in the sense that the rural is more active in this area than the urban is, and the suburban is somewhere in between. We also see on this one that it's getting closer back up to that 0 than it was on the left-hand side for the workplace. So this can tell us on an ongoing basis what's going on in a particular location. You can also see here that there's some kind of convergence that over the past few weeks, things have stabilized for the moment, that we are at a reduced level from what we were in January, but that we are pretty stable right now. You can also see there's a difference between Saturdays and Sundays and the other days of the week. So as new data sources become available through technology and companies and public-private partnerships, we're certainly trying to take advantage of those in the analytics work that we're doing. Now, one question that's sometimes asked is, are we there yet? When are we going to be done? And this was asked more often in the beginning, but I think it's useful to use analytics and think about this a little bit. So I'm going to give you 2 examples. On the left-hand side is New York. You can see that they had a lot of cases back in April and May. On the right-hand side is a picture of the cases, the lab-confirmed cases for North Carolina. Now, I also, as I mentioned, I look at deaths and I look at them per capita. If we look at deaths and we take the true infection fatality rate, then this tells me for the state of New York, there have been approximately 17 to 34% of the population who's been exposed to COVID-19 and may have some level of immunity if they haven't died. Because for every 1 death, you had to have somewhere between 100 and 200 cases to get to that 1 death. This is consistent with the antibody studies from New York. It also tells us that we're not completely done, as the infectivity of the disease is such that it could continue to spread, although that can be helped with interventions. And that is consistent with what they're seeing in New York. They are starting to see a small uptake recently, probably related to activities increasing in the city and throughout the state. If you look at North Carolina, on the other hand, I estimate that the percentage of people who have been exposed to COVID-19 is less than 10%, and in Georgia, it's less than 15%. So these states are in a very different place than New York in terms of their remaining risk for COVID-19. And so this is something important to think about. We still have a long way to go, given what we know about herd immunity and this particular disease. When we look worldwide, we see a similar kind of thing where the worst hit countries using death per 100,000 people suggests to me that the worst hit might have somewhere between 10 and 25% of the population exposed. And there are many others, including the US, where nationally it's somewhere between 5 and 20% of the population has been exposed. And there are others below this, of course. And what we know about COVID-19 is that when the herd immunity and herd immunity for this particular reproductive rate would begin around 50 to 67% of the population. So you would need at least 50% of the population to have some immunity before the pandemic would truly slow down. That's if you had no interventions in place. It's certainly different if you're using masks, face coverings, and distancing. So in conclusion, you can see that there's a lot of different kinds of analytics that can be used in disease modeling. In this case, it's a lot of computer simulations with stochasticity at the back. We do a lot of statistics, a lot of data integration. And then in some of the other ones that Pinar presented, we've used optimization models and all kinds of other things. One of the things that you should also see is that the behaviors are really important towards what is happening with COVID-19 and indeed for any disease. And we need to try to understand what's going on with behaviors and capture those in our analytics. I would also say to always challenge the assumptions and the input data going into models. There are different kinds of models. They're sometimes asking different questions and trying to get to different answers, but you do see sometimes that some of them, sometimes a model might be missing something. So you may find something that I haven't thought about for my model, and I might need to add that. Also, you can see that engineers and operations research and analytics folks can be working in the public space and can have impact there, as many people from the Informs community have been doing both during COVID-19 and in other environments. With that, I will open up the floor for questions, and we would love to have some questions from you. Please submit them through the Q&A. I'm going to stop the share so that I can focus on the questions now. Before I stop the share, I will point out that, no, that's not true. I'm going to go to the questions slide for Informs. Pinar and I have our email addresses on these slides if you have further questions that we don't cover today. So please send us some questions. Nobody's asked about vaccine yet. Maybe somebody, oh, here comes a Q&A. So Pinar might want to take this one. I'm going to read the question out. Pinar, if you can come back on video, that would be great. The question is, I wonder if you have looked into the effect of delayed test results on disease progression. You know, certainly there have been some points in time when it took 5-7 days to get test results back, and that does have implications. Pinar?
Yeah, so we looked at this not using the detailed agent-based model, but a different one. Specifically, we were looking at the combination of testing, tracing, and isolation, or even if you don't do tracing, let's say you test, and even if the test is perfect, what if the isolation piece is not perfect? So unless it's combined, unless testing is combined with isolation, like you pull that person from the network of interactions, testing by itself is not really going to have a huge impact. And I think the testing delays relates to this a little bit. If you test, the test is positive, it's going to come out at some point, but in the meantime, if this person is continuing their interactions just business as usual, they will be spreading the disease. So this actually, brings up another thing that I want to highlight or re-emphasize. Julie talked about voluntary quarantine. I want to repeat the definition for this. So it basically means that if there is someone in a household who is experiencing symptoms or who is suspected to be exposed to COVID, maybe waiting for test results, so the entire household refrains from physical social interaction. So that's kind of our broad definition of voluntary quarantine. A person might be feeling perfectly fine, but if they live in a household with a person who may be at high risk at that point in terms of being infected and infectious, that person, despite feeling good, refrain from interactions. That's our broad definition of voluntary quarantine. And we actually showed in our models that voluntary quarantine can have a huge impact in reducing the disease spread. And this is something that even if we do not have testing, at the least we could implement voluntary quarantine based on symptoms. If there's somebody with symptoms in the household, it may or may not be COVID. We just be cautious, and all of us in the household follow voluntary quarantine. Even that has a very, very big impact. So some of the interventions really can be done at the personal or household level. I know sometimes we rely a lot on technology and may want to have a magic bullet that's going to solve all of our problems. But for complex, situations such as this one, infectious disease spread, a lot of it actually really ends up on depending on how individuals or households or communities behave.
Absolutely, and we do have some of that built into the model. We had to voluntary quarantine when somebody in my household had symptoms. It was hard, and it's possible for someone who can telecommute it is harder for someone who doesn't have paid sick leave to do. And so we're never assuming that 100% of the population is doing it, but for those who can, they should. The next question is from John Milna. With winter approaching, do you have any data-based insight on the impact of colder weather on COVID-19 spread? So I'll take this one if it's okay. So it's a great question. Certainly we know that for influenza, it tends to reduce in the Northern Hemisphere in the summer months, from April to August. And in the Northern Hemisphere, the months are reversed. That is probably for influenza due to humidity, temperature, and those kinds of things, as well, perhaps, as people being outside and not in closed spaces with each other. For COVID-19, most scientists don't think that there's a large seasonal impact from the weather itself or the humidity or the temperature. It does seem to spread in many different kinds of environments. There is some discussion that when we go from being outside in parks and beaches and things like that to being inside in spaces that are maybe not fully ventilated, that there are some risks associated with that. So that is one of the things that I am anticipating could have an impact on COVID-19, and especially as we go from kids are not in school as much in the summer, and then we bring them back in school. And even, other people might be taking vacations in the summer, although travel brings its own risk, of course. The other thing is that we are going to be coming into influenza season, and with two circulating viruses that have some similarities, there are concerns about that and its impact on the health system. I personally am hopeful about that particular aspect, as South Africa, which has an influenza season that started before ours, they actually saw influenza cases go down because so many people were distancing and wearing masks and those kinds of things. But this year, it's probably more important than never before that people get their flu shot and be really careful about it, because one of the viruses could be misdiagnosed, and two, you're using common critical resource like hospital capacity if things go badly, and three, co-infections could be possible, and we just don't know what might happen with co-infections.
Yeah, I would like to second Julie that I think, the flu shots are going to be more important than ever in terms of the impact of people being hopefully more careful in the coming weeks and months, continuing to wearing masks and limiting especially indoor interactions might help with flu, but we still don't have a good understanding on how these two things might come together. So I also want to make a quick comment about the vaccine, COVID vaccine, if and when it becomes available. So again, from a resource allocation perspective, it will be important for us to understand that's also related to the serology question that I saw in the Q&A. If we only have, like Julie explained earlier, a fraction of people who were infected with COVID and recovered, we only have a fraction of them confirmed via testing. So there are many other people, maybe some of us here on this webinar, we had COVID, we recovered, and we just don't know. And when it comes for the vaccine to become available for the broader population, if we do the allocation and administration of the vaccine without knowing who really needs it versus who may really not need it because maybe they already recovered and already are immune or partially immune, that will really, really impact what we can do with the limited amount of vaccine. So I think that's another area where some of our analytics or our tools, along with surveillance and testing, would make a big difference in how much impact the vaccine can have. I don't know, Julie, if you had any other
No, that's absolutely, and Pinar is really the first one talking about this. It's not laid out right now in the guidelines for distribution, but you heard it here first, and you will start hearing it in the next month or two as people pick up on what she's talking about. When we have limited vaccines, we need to start with people who don't have any immunity if we have two people with the same risk level. Let's talk just a little bit. I see a question on the herd immunity. It seems like a horrible means to an end. As you saw, our estimate, or my estimate, is that the US is far away from what is needed for herd immunity right now. If we were just to let this virus go and, just go completely back to normal, didn't wear a mask, didn't distance, didn't do anything, there would be many, many more deaths that would result. We would go from 200,000 deaths to maybe 400,000 or 600,000, or in the worst case, somewhere between 1 million and 2 million cases. There are a number of reasons for that, and we can talk more about it if you like, but that would be a very costly solution in terms of lives. And at least some of the interventions, like wearing masks or face coverings, while they have become politicized, they're a relatively cheap intervention that is widely available, and that can make a big difference. We'll start to see just a little bit of vaccine coming if it comes this fall, but really we'll start to see more of it in the spring and next summer. And then if there is loss of immunity to SARS-CoV-2 virus, which scientists think there could be, we may find that we have to vaccinate on a semi-regular basis. Perhaps you might need one every 2 years or something like that. I see that there's a question about test characteristics, including sensitivity, specificity. Pinar, do you want to take that one quickly? It says for active virus.
I think we are a little bit over time. I just want to be cognizant of time. Thank you, Patricia, Kerry, practice section, Pelin Pekun for organizing, and thank you, all of you attendees, for joining us today. I believe there is a follow-up session after this, networking. So Patricia, over to you, and maybe we can continue the discussion there.
Well, thank you very much for this informative webinar, for showing us how analytics can solve so many problems and how it can be used to have accurate policy and what we can do, to stop this pandemic. Thank you very much. And if participants want to stay in this Zoom session, they can participate in the networking event that is organized by the practice section of Informs. And Rajesh will continue with this session. Thank you very much, Dr. Swain and Dr. Keskinokak.